Hello and welcome to this LinkedIn Live event. Listen to Heart and Kidneys and Diabetes, Revealing Silent Threats. This is a very appropriate day to be holding this event as we acknowledge World Diabetes Day. My name is Berard. I'm a nurse educator and diabetes nurse specialist in Canada, based in Winnipeg. I'd like to welcome you to this important discussion amongst world-class experts on early identification of kidney disease and cardiovascular risk in people living with type 2 diabetes. Today, I am joined by Sabine Dupont, who's a Director, Strategy and Policy at the International Diabetes Federation in Europe. Peter Rossing, who's a Chief Physician and Head of the Department for Complications Research at Steno Diabetes Center in Copenhagen, and he's also a professor at the University of Copenhagen in Denmark. And also Olivier Wong, he's a consultant for health technology assessment, early engagement and market access in the EU and China. He's a lecturer in health policy at various institutions, and he's a former member of the French Transparency Committee. He's also the Chief Medical Officer at Medi-Qualité Omega SARL, France. So welcome to my colleagues and thank you for taking the time out of your busy day to be here for a very important event. So what are we going to accomplish in our 30 minutes together? What we'd really like to do is talk about why we should be paying attention to kidney health in people living with type 2 diabetes. We also want to discuss how we can detect kidney damage and cardiovascular risk early and what this means for our patients. And then we're going to identify the key barriers to widely adopting regular testing for kidney damage and how we can potentially overcome these barriers. So at the end of our discussion today, there will be an opportunity to ask our panel questions about things that have been discussed or anything really related to the overall conversation about kidney health, UACR testing, and type 2 diabetes. So we encourage you to submit any of the questions that you may have through the chat box. So with that, I'd like to also highlight that all of us on this call today are members of a very important initiative. It's called the CHECK Initiative. Olivia, would you mind telling the audience about what the purpose of this CHECK Initiative is?
With pleasure. So our vision is for all people with type 2 to know the status of their kidney, basically, for healthcare professionals to take action with annual UACR testing to safeguard cardiovascular and kidney health. The mission is to motivate the medical community to UACR yearly testing in adherence with international and country-specific guidelines. But beyond that, it's probably to spark fresh ideas and forge partnerships that support the education and information needs of multiple stakeholders in kidney health. You can know more looking at our website, check-kidneys.com.
Thanks very much, Olivier. And Peter, maybe, you know, we're very dedicated to this initiative about raising awareness about kidney health. So perhaps you can tell us why it is so important to detect kidney damage in people with type 2 diabetes. And really, why is this something that we should care about?
Well, kidney disease is unfortunately a common problem in type 2 diabetes, and type 2 diabetes in itself is a very prevalent disease. So more than 500 million people suffer from type 2 diabetes around the globe. And approximately 30 to 40% of them will have kidney disease. And the kidney disease is a disease which can lead to higher risk for cardiovascular disease as well as kidney failure. That is associated with a lot of, you could say, disease, a lot of poor quality of life. So therefore, we would like to avoid it or treat it and prevent progression of kidney disease and prevent the cardiovascular complications. But one of the problems with detecting kidney disease in people with type 2 diabetes is that in the beginning, there's no symptoms. There are no, you need to look for it in order to identify it. So that's what the CHECK initiative is also about. We need, as Olivier said, we need to make people look for kidney disease so we can detect it as early as possible, so we can intervene and stop the progression and deterioration of kidney function, and also mitigate or handle the excess cardiovascular risk.
So recognizing what you've said, Peter, is that, you know, we need to be looking for it early, but there seems to be a gap in that actual diagnosis. Hence, that's why we're here having this conversation about how important it is for us to be thinking about kidney health in our patients. So Sabine, how do patients typically react to a diagnosis of late-stage kidney disease on top of their diabetes? And really, what are some of the consequences of such a diagnosis for them?
Yes, thank you, Laurie. Yes, as you're saying, as you say, diabetes is a hugely complex condition to manage. And we know that it needs to be managed well in order to avoid complications such as chronic kidney disease. And for that, we need access to the right treatment, the right education, the right support. And we also know that out of the millions of people living with diabetes, about a third of them are undiagnosed, which places them at an increased risk of complications, and that about a third of them already show signs of complications at diagnosis. So when you get diagnosed with diabetes, with type 2 diabetes, you have to start juggling with medication, perhaps change your lifestyle. Also look at the stigma, and there is a lot of stigma attached to type 2. So that creates a huge burden already for people living with diabetes. So if you add to that a diagnosis of chronic kidney disease, particularly at a late stage, whether it's at the same time as you get diagnosed with diabetes, or actually once you've already tried for many years perhaps to manage it well, then it's a huge shock. And it really adds to the burden of management, because the treatment of late-stage kidney disease is very burdensome for the person living with diabetes. And it also has a huge psychological impact. And we know that people living with diabetes are at a higher risk of depression, perhaps twice as high as people without diabetes. So the consequences of that diagnosis are really profound.
And as you say, too, it's late stage, and I'm sure many of them would have really embraced the idea of knowing earlier that this was a risk for them, instead of the shock that comes later on when they're already dealing with other complications. So Olivier, maybe you can explain to us a little bit about the economic consequences of this delayed diagnosis of disease.
The economic consequences are huge, and they are somewhat catastrophic. Why? End-stage kidney failure does cost roughly 50,000 euro in Europe per patient just for the dialysis alone. So that is not affordable to have a syndemic, like a pandemic of type 2 diabetes mellitus, and we have to do more in order to prevent end-stage renal disease. It's not just a matter of economic consequence and offsetting the costs, it's also, of course, the societal cost, and beyond the societal cost, it's the capabilities. Because if tomorrow, for example, government wanted to invest more billions in nephrology for end-stage renal disease in Western Europe, for example, we don't have human resources. We don't have the capacity to upscale anymore. We have at the maximum. So it's why there is no choice than to have better detection, early diagnosis, in order to slow or stop, hopefully, the progression of the disease by a better management. And this is also a concern for the health inequalities, because the early diagnosis is more for the higher educated population, where the low educated population gets more often late diagnosis. So that is a concern for public health decision makers across the globe.
Thank you, Olivier. It was such a wonderful summary of sort of where we've started and where we've gotten to, and what the consequences are, not only, you know, we've talked a little bit about to the person living with diabetes, but also to the healthcare system. So Peter, let's turn to you. So really, if this condition is silent and the patient doesn't have any specific symptoms to report, what are we supposed to be doing? Like, how are we supposed to detect this?
Well, fortunately, it's actually quite easy to detect if you just do it. And that means, what should you do? You should test a blood test for what's called creatinine or kidney function, which is a simple blood test. And then you should test urine for the excretion of albumin or protein in the urine. Now, these two tests go together because you can say one, the blood test is kidney function, the level of the filtering function of your kidney, and the urine test, the albuminuria, reflects the kidney damage. So you have function and damage, and you need both. Like when you do dancing, tango, you need to be two. So like kidney testing, we need both of them. And often people have their kidney function tests. Actually, we can see in most countries, most people with diabetes are checked once a year for kidney function. But very often, people are not tested for albuminuria. And it's very simple. You just make a morning urine sample, and then you test it for albuminuria or albumin-creatinine ratio, which is an evaluation of your kidney damage, as I said. So it's very simple. It's actually also quite cheap. So in that sense, everybody should have this performed if you have diabetes every year to check the status of kidney function and kidney damage. And it's really important, whether you're seen by a primary healthcare professional or a specialist like me, you need to have this performed every year. So you can say it's the responsibility of the person taking care of you. But if you have diabetes yourself, then you can also contribute to this process by being aware that you should have this tested every year. And if testing is not happening, you should tell your doctor that maybe there's something he or she needs to do.
So thank you for that really wonderful summary. So if I take away your key messages are, everybody needs to have this done with type 2 diabetes. And so it's really simple. It's a blood test and a urine test, but it's not a urinalysis. It's a urine albumin creatinine ratio. So it's a little bit different. And you mentioned that it could be done should be done in the morning. But I think sometimes if we're not doing it at all, just doing that test at any time of the day, if it's being missed, is really important. But preferentially, it's done first thing in the morning. And then the other thing I heard you say is that it should be done once a year. But I think, Peter, what we really need to identify is that for decades, all of the guidelines around the world around management of diabetes or detection of kidney disease have been stating to us that individuals who live with type 2 diabetes should have a UACR and eGFR done at diagnosis, so that blood test and that urine test at diagnosis, and then at least every year afterwards. But I think we're recognizing that there's some gaps in this so that we're not necessarily getting this done. So Peter, in your opinion, who should be actually ordering these tests?
Well, as you say, we are far from achieving that everybody is being tested every year. And in many countries, it's only 50% which have a test every year. So 1 in 2 person have a test. So we really need to improve on this. It's a very simple test. And as you said, it can actually be done any urine sample. We used to have 24-hour urine collections, and that was considered to be very cumbersome. And people say, well, I can't manage that. But today we just recommend a simple urine spot test, and that is very simple to do. And you can say it's the responsibility of the person managing your diabetes, which can be a primary healthcare professional, it can be a diabetes doctor like me, or it can be a nephrologist if you have advanced kidney disease and diabetes in combination. But often it's a primary care physician. In most settings, 80 to 90% of people with type 2 diabetes, if not everybody, are seen by a primary care physician or general practitioner on regular intervals to check for diabetes management and the occurrence of diabetes complications. But as you said, people are busy, so it's not always that they remember to have this urine test performed, but it's really important. And as a person living with diabetes, you can contribute to having this done by simply knowing that this is something you should be aware of, like you should know your blood pressure, you should know your cholesterol and your glucose, and you should also know your albumin creatinine ratio.
Excellent. So again, a reminder, if you have any questions about anything that's been talked about, please put it into the chat. So we're here today because we're raising awareness around the need to be checking kidney health in people living with type 2 diabetes. And I think one of the things that we understand is that it's done very poorly in most countries in the world. Certainly there are countries that are stellar at this. They have it built into a performance checking, so that you see 90% of these patients that are having their UACR done as they're supposed to be. But many countries in the world, the rate of adoption of UACR testing is between 30 and 40%, which is very, very low considering the numbers of people living with diabetes and the number of people living with type 2 diabetes who are affected by kidney disease as well. So we have to think a little bit about what some of the barriers are. And I think we've done a really good job over the years of making sure that primary care providers and people treating diabetes understand that you have to check glucose and blood pressure and cholesterol. Maybe we haven't done such a good job of reminding them of the screening that we can do for the detection of kidney disease. And we know that some people think that the EGFR is enough, but in fact, we know it isn't enough. It's just really where your kidneys are at. The UACR tells us how quickly that disease is progressing. And I think there's a little bit of confusion. And I mentioned, you talked about the big test, the 24-hour urine test, which I've been around long enough and we did a lot of those, and they are complicated for people to do and they need a timed blood test. But now we have a very simple spot urine collection, but it is not a urinalysis. And so we have to make sure that we're ordering the right test. And sometimes there's the ability to do a point of care test, or there may be a dipstick alternative that can be used for UACR testing. So Olivier, regarding this, UACR may be the best option, but recognizing that this is what we need to do, are there challenges in terms of clinicians actually being able to order this in terms of being able to do appropriate screening?
There are many challenges. First of all, lack of awareness by at least some of the HCPs, we should recognize. The second thing is probably what we call clinical inertia, which means doctors know what they have to do, but they don't do it. Why they don't do it, it's pretty complex, and probably we have to think outside the box on whether we should open new channels, like option for self-testing at the point of care lab, empowering primary care nurses when available, empowering pharmacies, patient advocates to play the role of a prescriber, because basically the cost is very cheap. Most payer organization does reimburse, at least in Europe, but in most, let's say, developed country, in emerging markets. So the cost is not the issue. It's more the clinical inertia. And the way we've seen in other chronic diseases to tackle clinical inertia was more to think as a team and not just as a poor overload GP does not have the time to do everything and would just bypass UACR, where maybe Sabine and Peter could, and Laurie, you could empower a team at the local levels that would be able to do it. And with artificial intelligence, with share electronic data, now it's probably a new area where we should boost from 30 to 98%, let's say. We have to be ambitious.
Great. Thank you. And Peter, I think something else that is really a challenge is that getting this UACR doesn't really help clinicians in terms of management decisions. So when a primary care provider is really busy and they don't have a lot of resources and they order this test for this diagnosis, what can they do to change the course of patients' care and outcomes?
Yeah, I think it's important that people need to understand that there's, of course, a reasoning why you should do this test to evaluate kidney damage. And the reason is it has prognostic information, so it tells you something about the future, the risk for cardiovascular complications, kidney complications, and also for mortality. But the other thing which is really important is you can take action based on the values. And for many years, I think, we have just had blood pressure medication blocking what is called the renin-angiotensin system as standard of care. And most patients with type 2 diabetes are already on medication for hypertension or high blood pressure using these agents. So there was a trend saying, well, maybe we don't need to test because we will not change management anyway. But in the last 6 to 7 years, we have seen fantastic progress in the opportunities we have to treat kidney disease in type 2 diabetes, but also in other kidney diseases. And these treatments rely on the risk for or of having a risk for progression of kidney disease or having poor kidney function. So if this is present, that means you need to take action and implement these new treatment options. And we have had several treatment options, and they seem to go together, so we can really make a difference for people with kidney disease and diabetes if we start. And the earlier we start, well, the more we gain, the more time we gain by postponing loss of kidney function and development of kidney failure or end-stage kidney disease. So I think it's really important that people understand that by this simple test and by taking action, you can change the future for a person living with diabetes and potentially developing kidney disease.
Thanks, Peter. I think we can all agree that a lot of providers became quite inert around managing kidney disease because, as you mentioned, we just used the blood pressure medications, the ACEs and the ARBs. But the world has exploded in the ability to do better things for people living with type 2 diabetes and CKD. So this is kind of a call to action for our providers to think about doing adequate screening and to provide this type of care. And so, Olivier, there must be some economic impact of regular UACR testing and guideline treatment. Any thoughts on that from the standpoint of the health system? We've heard about the providers, now the health system. What would that do?
Of course, it's highly cost effective to have early intervention. As Peter says, we have RAS inhibition. It's not always done at the early stage of the disease because not all patients have high blood pressure. Many patients get undiagnosed. So I think at the early stage, we can win a few years on delaying deterioration of CKD. So that is highly cost effective and also does provide a better health, better quality of life in the long run. So if the public health benefits are like obvious. In a later line, it's true that for you guys now you have new class of drugs that have been shown as being also cost effective with a good hazard ratio on delaying renal events, kidney damage, and cardiovascular events. So that is quite new. It's quite exciting for the medical community, and this does provide hope to delay strong deterioration and end-stage renal failure, among other catastrophic cardiovascular events. So I think there is hope. You can't say now that, well, it's just type 2, you just have to change your lifestyle and there is nothing to change. That was probably true in the 60s. That's not anymore true in 2023. So it's good news for patients.
And that's a great segue. So Sabine, really tell us about, what this could really mean for the patient in terms of understanding the need for regular testing and early detection and what effects this could have on raising awareness amongst them and really helping individuals living with diabetes understand this in terms of, advocating and empowering them for their own care.
Well, I think that indeed what is critical for people living with diabetes is to be well educated and well informed at diagnosis of what their risk of complications is, so that they can be full partners in their care. And there are now many ways that people can be well educated and informed. And it used to be that the information was hard to find, but now it's easier to find it. You have some platforms indeed that can provide the information. But nevertheless, the person that remains key in this is the healthcare professional. So as much as we need people to be well informed and educated and be able to raise awareness and to talk to their healthcare professionals, we need the healthcare professionals to be well educated in the need to empower people living with diabetes, to listen to them and to engage with them. So that's one aspect of it. And so we need to have more than just the treatment aspect being discussed by healthcare professionals. Well, we need them to be well informed about CKD and the options for treatment, but also be well aware of what they need to support people living with diabetes. And of course,
and I'm a big believer, Sabine, is that we empower our patients. And so if we're informed, then we can really help our patients make choices and ask for things. So exactly. I really think that we all need to be better at this. So thank you.
Exactly, but we also. I just want to say one more thing, and it was in relation to the burden. We need a change in the way that the healthcare system works. We need a much more person-centered and integrated care approach, because the person living with CKD probably lives with other complications, or might live with other complications. And if we want people to remember to ask for a test, then it's much easier if we have a system by which people are actually reminded, or healthcare professionals are reminded, that they need to have that test done. And AI and digitalization of healthcare system, I think, will have a big role to play to that, because it will enable us to detect people at risk, but also to look at the effectiveness of treatment, to predict the progression of the disease and the people that are going to be at risk. So I think that there is a huge potential for innovation to help also solve that problem.
Excellent, Sabine, because you've answered one of the questions in our chat, which is about how AI will impact diagnosis in this therapeutic area. So thank you for doing that. Olivier, maybe I can ask you to just sort of let our audience know where they might be able to find more information about CKD, DKD, and guidelines.
Yes, well, in each country, you have the country-specific Society of Diabetology that publish the guidelines. Sometimes it's an authority like NICE in England, or HAS in France, for example. You can have also a look at the website of CHEC, but also of the patient advocacy group, which is usually very well connected with all the information, including guidelines. So the information is not hidden. It's very easy to find it on the web.
Right. Thank you. And I think, Peter, you probably would have also guidance around some of the other places that we might go in terms of things like KDIGO. So I'm going to ask you to comment on that, but I'm also going to ask you to answer this question from our audience as well about how can you implement a proper system in the clinic to make sure that you incorporate this testing in practice. So a little bit more about where to find information, and a little bit more about how to implement screening in your practice.
To find information, as Olivier said, patient organizations, national or international, have a lot of information. KDIGO, as you mentioned, is an organization which issues guidelines on many topics related to kidneys. And they have developed a guideline for diabetes and kidney disease. And for that guideline, there are also a patient leaflet, 1 page, 10 points, easy to remember. And there's a similar page for the healthcare professional, easy to remember, 10 small points, which tells you how to detect and treat kidney disease. So in that sense, you can get easy information from that, and it's translated to many languages, but developed originally in English.
Great. And quickly,
maybe for the clinic, you mentioned, how can I set it up in your clinic? Well, you need to have, for instance, an annual check where you have blood pressure, glucose, and feet, eyes examined. And then in relation to that, you need to have a system which reminds you to check the urine and send it for a urine albumin creatinine ratio. We have a national quality monitoring system that helps us. And we have an electronic health record system which also tells me, hey, it's time to measure albumin in the urine. And it also helps me by saying, hey, here is albumin creatinine ratio elevated. You should consider using one of these new agents to protect the kidneys from progression. So in that sense, I get a lot of help from the systems. And I think that's important, that we take advantage of what systems can offer, because otherwise we need to remember too much and then we forget.
Great. Well, thank you. And it's my responsibility now to close this on time. So I'd like to thank you all for participating in this important call to action. And for you, the audience, really, you can act now. It's time to start the conversation with your patients who have type 2 diabetes about their kidney health. You need to take up the challenge to increase the UACR testing rates for people with type 2 diabetes and provide them with an opportunity for early intervention to protect their kidney and their cardiovascular health. And you should spread the word by sparking discussions about this topic with your colleagues. Bring it up at all the diabetes talks that you're doing. Make sure that you're talking about it in your clinical rounds. Remind people that this is really important. And also, if you want more information, please remember to visit our CHEK website, chek-kidneys.com, for information and resources, and how you can learn more about the topics that we discussed today. So again, thank you for everyone to taking time out of their busy day, especially our speakers, and I wish you all a great World Diabetes Day. Thank you.
Thank you.
Bye-bye. Thank you.
Bye-bye.